Hey, good morning, everybody, or afternoon for anyone on the East Coast. This is Tim Needham with the Burwood Group. We'll get rolling with the webinar. As an overview, this is a recap of a presentation that was done at the AMI conference several weeks ago out in Long Beach. We just offering this up for anyone who was unable to attend the session since it was late in the conference. Start off today with the title. It's Methodology for a Comprehensive Clinical Communication and Alarm Event Notification Implementation, which we joked at the conference is a mouthful we won't say again, but we'll start here by talking about the presenters this morning. With us, we have Mary Kate Florian, who's the Patient Service Manager with the Yale New Haven Children's Hospital Neonatal Intensive Care Unit. We have Carol Salerno, Clinical Nurse Informatics Specialist with Yale New Haven Hospital. We have Samantha Harold from the Clinical Engineering Integrations Team at Yale New Haven Health. And I'm Tim Needham. I lead our advisory practice here at Burwood Group, focusing on connected care. Thank you for joining. I'm going to start briefly with some objectives for today. We'll use the term connected care quite often. As some background there, we use connected care to identify clinical communications technologies and processes, basically bucket everything into that title, so you'll hear that. Some of the key objectives are appreciating that these systems have matured enough that we feel it's worth taking some risks. And you'll understand that the Yale project had with it complexity risk, it had timing risk, it had engagement risk. This is a kind of a walkthrough of how the team overcame those risks to deliver a pretty compelling project. We'll speak to the benefit of the interdisciplinary team that was involved in both designing the system and implementing and testing. We'll talk about the clinical workflow and the role that drove not only in system design, but also in engaging the clinical staff. And lastly, while this project you'll learn through the presentation was focused on the neonatal intensive care unit at Yale New Haven Children's Hospital, the lessons and the methodology are applicable to implementations outside that environment or system-wide implementations. At this point, I'll turn it over to Mary Kate from Yale New Haven to provide some of the vision behind the project.
Hello, everyone, and thank you for coming to this webinar, and thank you, Tim, for introductions. We're all very proud to be here today to tell you about our story of where we've come from and where we are today. 3 years ago, we began our journey to design a premier state-of-the-art NICU, building single and double patient care rooms that would support the safe delivery of care, patient care quality, and patient and family focus in a patient and family-centered environment. Apologies, everyone. We opened this new NICU this past January. This vision wasn't new to Yale New Haven Hospital. We actually have a rich history of ensuring the state-of-the-art technology and advancements in the care of premature infants. 58 years ago, we were the first unit to actually create this environment by combining premature sick infants and sick full-term newborns. That environment was called a newborn special care unit, today known as neonatal intensive care units. This open bay design was replicated all over the world and supported for years to come, believed to be the best monitoring and care environment for these patients until the evidence showed us different. Our current design that we had for the last 15 years, and actually, again, since we opened, was the single bay design. Our current unit that we moved from in January was a 52-bed unit covering 10,000 square feet of space. Those 52 beds were located in 4 large rooms that accommodated 10 patients and 2 small rooms that accommodated 6 patients each. The resuscitation space was logistically located directly across the ICU, just a hallway width away. When help was needed, everyone was aware and could immediately respond. 250 staff plus the providers worked within the small square footage, 10,000 square feet space to care for these patients and the families. The first picture to your left represents one of those large rooms, and you can see how chaotic that room and that space looks. This open bay design, though, supported clear visibility and alarm notification to caregivers, immediate response and access to all patients, better situational awareness for all caregivers due to direct visual and verbal communication. In fact, we didn't have any communication devices in the unit because we were in such close proximity. Lastly, it supported increased contact with parents. Parents loved it because they could see the staff all the time while they were sitting right next to their baby and visiting. At any one given time, in each of these rooms, there were 8 to 14 staff, plus providers and families. When an emergency happened, such as emergency surgery, it was addressed by the OR team coming up into the room. We had to close off the room, but that room remained with neonatal staff and providers in that space with OR to care for the patient. The downside was we did have to ask parents to leave the room for the extended period of time during the surgery. This environment, through audible alarms and visual cues, I always like to call it the eyes and the ears of the unit. It supported a flow of immediate information to all caregivers in the room that the patient was in distress and direct action was needed to be taken. However, as you can only imagine, having 10 to 12 patients per large room, these spaces were extremely overstimulating for not only the infants and their families, but all the caregivers. On the right side, the picture you can see is one of our new rooms that we just moved into, patient care rooms that we just moved into in this new environment in January. I'd like to go on to describe that new environment. So we moved from that old environment to a now 68-bed patient environment of single and double rooms. We're now located on 2 main floors that equal 44,000 feet, more than quadrupling our old unit space. We also have the resuscitation bay, but now it remains on the 4th floor where our old unit was. We are now on the 10th and 11th floor. On the 10th floor, we also additionally have a new model of care that encompasses what's called NICU neonatal couplet care. We are the only level 4 NICU that has this currently in existence. This allows us to admit a neonatal patient in with a newly delivered mother together for their care the first couple of days until the mother is discharged. And the baby will either then go home with the mother or the baby will be moved into a single or double neonatal room. On the 11th floor, we have a separate large procedure room and a pharmacy. So as you can see, the environments are totally different. Next slide, please. Each floor has 3 distinct and separate care areas caring for 10 to 12 patients and families. You can see from this rendering is a picture of one of the care areas. Better to understand, in the design of the Children's Hospital, it really replicates a clover leaf design. So there are 3 distinct areas like a clover leaf. The evidence showed us that the single design would decrease stressful stimuli, enhance patient and infant interaction and bonding with the parents, and enhance overall wellness for everyone. So you can see from this design, how could people not like this design? The design provoked fear in many of our staff and providers, and when I really say fear, they were really scared. They just couldn't imagine how they were going to be able to transition from what they knew of how they were caring from our patients in the old design to this new design. They saw the new design as challenging their ability to have direct audible visual assessment and cues, loss of situational awareness and ability to respond immediately. Everyone was separated. That was a big issue. How would they get in touch with people? How would they know somebody was coming to get them, to give support? Next slide, please. Thank you. We actually did a pre-launch survey, which did substantiate what we felt, that people were terribly frightened of this new environment. They just couldn't imagine how they were going to meet the needs of their patients and help support one another. I actually had one nurse come to me in tears, so frightful that this would not be able to be sustained. In a pre-move survey, we showed that only 27% of our staff and providers were excited about this new move. We knew that we needed to design and integrate the technology around our care practices and operations, connect the caregivers and providers to their patients, families, and each other in order to change their behaviors and their mindset. We did this we knew we needed to do this by connecting the patients' families to each other, and we needed to do this by leveraging our technology. I'm now going to introduce you to Sam, who's going to tell you and talk to you about how we were able to do this. Sam?
Thanks, Mary Kate. So the overarching challenge that Mary Kate was talking about that we needed to solve was how to address those concerns and make everyone feel comfortable in the new space. So what is the connected care system, as Tim introduced? It refers to the technology solution that brings our three pillars, the baby, the family, and the caregivers, together through alarms, alerts, and communications. Our design of this solution was based on these guiding principles you see on your screen. First, making sure our three pillars did remain connected in the new space. Second, that caregivers could contact their team members easily and efficiently to support team-based care. As Mary Kate said, the new space is broken into 2 different floors with 3 care team areas on each, and we've identified that those care team areas are really an extension of the patient room. The caregiver in one room would have to be able to reach any of his or her teammates for help. Lastly, we had an extremely short timeline. Our go-live date was determined based on several other construction timelines, so we had to meet that goal. Our project plan was developed backwards from that date. There was very little flexibility, and all resources had to be dedicated. Next slide. Speaking of project resources, this project obviously required a lot of commitment and support to encourage teams to meet the deadline. We could not have done this without leadership buy-in. We needed dedicated and knowledgeable nurses, physicians, informatics nurses on our design team. We needed our Burwood design consultants to keep us on track. And what I want to highlight on this slide and just bring to the attention of everyone is the really specialized group within Yale. Oftentimes, biomed groups ask how they can bridge the gap between biomed, the clinical side, and IT. So this is Yale's solution for that. Within Yale New Haven Health, the clinical engineering department falls under IT, and within clinical engineering, there is a special team dedicated to integration, the clinical engineering integration team. The people on this team, we have experience working as clinical engineers, managing projects, but are also specialized in integrations and IT applications of biomed. The background of working with medical equipment and supporting patients from clinical engineering, combined with the knowledge of, let's say, data transfer servers on networking, made this team really valuable members of the project. There were 2 leads from the team, myself and my colleague, Joe Willett, and we were supported by our other team members during the extensive commission testing, which we'll talk about in a little bit. Next slide, please. So the interdisciplinary team was able to maintain a multifaceted collaboration to allow the care delivery model to drive the technology design. We did not implement technology and force them to change their care delivery. This means that the right information is delivered to the right person on the right device at the right time. We looked at the people who needed to stay in contact with each other, our 3 pillars, and what endpoints we had to connect. Next slide, please. So what did we connect? Using Connexall middleware, caregivers receive clinically significant secondary alarms from physiological monitors, isolates, and ventilators on their mobile devices. Yale happens to use mobile heartbeat to accomplish this. Additionally, caregivers receive communications from the patient's family and other caregivers from the Rowland call system. Dome lights and console tones provide further visual and audio information to the source of the alert. We also connected our infant security system. The challenge for us on the CE integrations team and working in conjunction with our Burwood technical architect was to determine the best way to integrate each of these components. For our physiological monitors, we were able to use a direct HL7 integration, but our ventilators, for example, we utilized capsule technology in conjunction with an ADT feed from our EMR. For the isolates, however, we had to integrate through the nurse call system, which utilized a SIP-to-TAP gateway to get the information over to Connexall. Connexall, our middleware, then takes all of this information and distributes it to the right person based on staff assignments completed in the Connexall software. Next slide, please. So where are we today? Well, due to the design team's diligence in sending only clinically significant alarms to mobile devices and other alarm management initiatives within the Philips monitors, which we'll talk about in a minute, noise was down on the unit. Our quantity of alarms are also down. The alarms do not startle other patients, reducing unnecessary stimuli. Families and patients are more comfortable due to increased privacy, but know that they can still call for help when needed. This quote below is from a post-go-live family survey. It's fantastic to have a private room. Good balance between having an RN in the room and being able to have family time. Due to the alarm management, the environment is quieter for babies because they're not in physical distress. They too alarm less. They're actually so calm now that our volunteer cuddlers are looking for things to do. Next slide. So let's talk about why the unit is so quiet now. Well, as I mentioned, the design team did a great job in managing the physiological alarms. First, red alarms were changed to be non-latching. So if a patient self-corrects, the alarm turns off, which is very different in my experience to how most red alarms are configured. Second, the use of profiles and smart alarms within the Philips patient monitoring system allows for alarm parameter customization and tiered alarms based on patient gestational age and the percent of oxygen they are in. Third, only red alarms are sent to mobile devices, i.e. those clinically significant alarms as determined by the clinical design team. The secondary alarm routing allows for a faster response to alarms. All of these factors contributed not only to a reduction in the number of alarms generated, but the time a monitor was alarming was also reduced. This data was collected using our big data server, Hadoop, which our physiological servers send direct HL7 messages to. We were able to compare 2 months of pre-go-live data, our go-live date was January 30th of this year, and compare it to 2 months post-live data. As you can see in the old unit, we had red alarms sounded for 322,000 minutes in those 2 months, where yellow alarms sounded for 387,000 minutes. The number of alarms we had 63,000 red alarms in those 2 months and almost 1 million yellow alarms in just those 2 months before go live. Implementing those changes, having the tiered alarms for SpO2, changing the red alarms to be non-latching, we reduced not only the number of alarms we had, but also our minutes that the alarms were sounding. We dropped from 322,000 to 2,600 minutes just for red alarms and down to 114,000 minutes for yellow alarms. And with that, I will pass it back to Tim.
Thanks, Sam. Hey, just something I forgot to mention up front. I think Rachel from the Burwood team had sent out a note via the WebEx chat. But if you have any questions, use the chat function. At this stage, though, I wanted to take a break. When we did the presentation in Long Beach, we took a break here to ask. We'll have some Q&A time at the end, but at this stage, any questions on the alarm data? I can reflect back one of the questions that we did take at this point in the conference as well. But we've unmuted everybody. If there's anybody who has a question out there, please fire away. Okay, well, I'll go ahead and the question we got at the conference that we thought was pretty interesting was, all of this data didn't come just from the technology and secondary alarming, this reduction in alarms. It wasn't the technology alone that did it. And I think it underscored one of the key components of the project, that it was the combination of secondary alerting with the upgrade with Philips, with the process changes and the evaluation of what's important, what's not important by the clinical team. And we definitely wanted to volunteer here that if we had merely, with the graph on the left, if we had merely turned on secondary alarm notifications and sent all of those alarms to the mobile devices, we would have absolutely overwhelmed the clinical team day one and run into severe alarm fatigue. So it's an important opportunity to underscore the importance of the combination of secondary alerting with process redesign and evaluation of alarms and historical data, and then making sure that the monitoring technology is operating at a peak performance level in terms of being upgraded, et cetera. So again, this is neat. Running the numbers, it represents about a 72% reduction in the red alarms, somewhat in an overnight capacity in terms of the change. about 66% in the yellow alarms, and then from an actual minutes of red alarms, it's literally in the 99th percentile in terms of reduction. So I just thought this was a great example of underscoring what's possible with focused team effort and that interdisciplinary design. All right, we'll go ahead and jump on, and we're going to talk a little bit about the timeline on the project. Overall, we're talking about an effort that construction began before October 2016, but October 2016 was really when the clinical team, led by Mary Kate, put their hand up and said, wait a minute, we need to understand how this is going to impact caregivers day to day. When we look at the actual compressed project itself, when we implemented all of these technologies that Sam outlined in that connected care environment, it was actually a 7-month project, start to finish, with 5 months of that really being the design, implementation, testing, redesign, and training completed. The last 2 months of the project were really just allowed for activities leading up to the go-live date. So it's a pretty good counterpoint to what we typically hear in the industry. The vendors gave us feedback initially that they would typically allow 12 to 18 months for this project, and they were definitely concerned about the timeline, but the team at Yale here really proved that these projects can be escalated and executed quickly. Specific detail here on the go-live week, Monday was used for audit and walkthrough. Tuesday, the 30th of January, was the date that the babies were moved along with the families. We're talking about a 7-hour window. It's important to note that on Wednesday there was a critically ill baby that coded. Just a sad situation in that it didn't turn out well for the family and the baby. But what was important to note about it is that once the team got through that experience, they pulled back together and we did a debrief of everything that happened, and it was validated that the technology worked exactly as planned, and it gave everybody the best opportunity that they had to try to intervene on behalf of the patient. So it gave some consolation to the team that everything was designed how it was expected. And then by Thursday, it was the handover time, and Go Live team was released. So it was a fairly smooth thing. Carol will talk a little bit more in detail about that week, but I just wanted to give that perspective of the overall project timeline to you guys because we think that's pretty key. Before I turn over to Carol for the methodology review, just a quick highlight of what we're going to cover here. We typically, from Burwood's perspective, when we interview clients that have been through this process, we see anywhere from 15 to 17 key steps and pieces we go through. This is a sampling of some of the most critical. Engaging the design team, especially the clinical team, to make sure that the workflow is driven by clinical use cases that the care team can connect to. We'll talk about a user acceptance testing process that allowed for rapid evaluation and redesign, which helped us with the time frame. We'll talk about the training process. We'll talk about commission testing and the role it played, as well as the little more detail in the Go Live support. And then I'll bring in some more of the vendor assimilation as I close out the presentation today. So Carol, I'll turn it over to you.
Thanks, Tim. As was previously mentioned, key to this project was using a design team approach. This created a group of champions with continued engagement throughout the implementation process. This was an interdisciplinary team of approximately 25 members who met for 18 and more hours to evaluate current processes and determine the needs for the staff as well as the patients and the families in the new environment. The team included physicians, nursing, respiratory therapists, business associates, patient care associates, family support specialists, and also included ITS support and clinical informatics. Each team was at the table to address the issues specific to their department. The team was given baseline education on the new technologies, then utilized simulation and workflow review to understand the changes from current state to future state with the connected care. These systems were then evaluated, and the team developed processes to ensure the right information was given at the right time to the right caregiver on the right device in the new care environment. Next slide, please. Workflows were designed based on 3 different components: staying connected to your patient, staying connected to your patient's family, and staying connected to the caregiver team. So as this graphic shows, it's bidirectional. The infant sending alerts via physiological monitors and the caregiver responding to correct that infant's condition. The parent sending a message asking a question or asking for assistance and the caregiver responding to that need. The caregiver in the room sending an alert to ask for assistance or help with a critical issue, and then the team being able to respond. Once these workflows were designed, simulations were used to evaluate the decisions. Next slide. These designs went through several iterations. There was the initial workflow design followed by simulations, which then led to a modified design. For instance, when we were around the table having discussions, it was felt that a critical alarm needed to be addressed as quickly as possible to set that secondary alert with a 15-second escalation pathway. When simulated in a real scenario in the unit, it was found that the caregiver couldn't drop their current task and respond to that alarm in that short of a time. They weren't even getting to the threshold of the room before the second responder was alerted and on their way. So this time was increased to 30 seconds. This was followed by an informal user acceptance testing, resulting in small changes before a final formal user acceptance testing. This was a quick process, but engaged the design team and helped them gain confidence in the system and their design decisions. Next slide, please. The design team consisted of frontline nursing staff who took on the role of trainers. These nurses were selected based on certain expertise. One was an experienced nurse who took on the role of charge on days. One was an experienced nurse who took on the role of charge on the night shift. One had past ITS experience, and one was a young, newer nurse who we thought we could relate to the needs of the novice nurse. Having this group engaged as part of the design team increased their understanding, and then they were natural trainers. They became known as the Fab Four by their peers, and they were true clinical experts with connected care. Training done by peers was felt to be very effective. The training focused on the workflow changes and not so much the details of the technology. Primary focus was on how to safely care for your patients, address the family needs, and get help from your team when needed using the new technologies. This single curriculum that was not controlled by vendors prevented the risk of vendor-led gaps or conflicts. Next slide, please. Commission testing. All teams and vendors knew the risk to patient safety, so there was a commitment to commission testing. No matter where this work was being done, even at an off-site location, the team was working on behalf of that infant they saw in the NICU. There was a 5 to 6 week process and a joint effort between consultants and ITS clinical engineering testing all devices, alarms, and workflows. In fact, there was many days I left the unit and Sam and her team were testing, and I came back in the morning and they were still testing, and I figured they had never left. This is not typically in the budget plan. Also during this testing, downtime processes were developed for planned and unplanned downtime. Next slide. It was very important to the team and the staff to have active go-live support. This provided reassurance that issues, if any, would be addressed quickly. There's 3 days of 24-hour on-site support. The design team and NICU leadership were part of the rounding team that checked in with staff and reported issues to the command center for review and resolution. This was key to making sure that the staff had the support they needed during this change process while still providing their everyday care to their patients. Minor issues, and to be honest, we couldn't come up with any ones to give an example, were resolved quickly, and it really proved that the countless hours of preparation and testing had paid off. Thank you.
All right, thanks, Carol. I'll close out with some takeaways. Key things we came up with in reviewing the project: executive sponsorship has been mentioned a couple times in the presentation, and whether it was Mary Kate and her chain of command and the clinical operations side, or the IT clinical engineering side and our executive sponsors there, we repeatedly saw a commitment to the project, an intent to keep people focused on the timeline, and a commitment to remove barriers that really did help the project. We talk about team commitment and shared goals. From my perspective, the Yale team was exceptional in terms of their effort and commitment. We really didn't see much wavering at all across what was a large group of stakeholders here. And the model itself, once we established the connected care model and we had that project planned, Sam mentioned building the project timeline backward. It really provided clarity, and that's a mistake we've seen made before, where projects treated as steps, not knowing what's next. And I think that the Yale team did a wonderful job of keeping focused on that model and sticking to it. The timeline, a little bit of a joke here that when we started this project, I think, Mary Kate, you were the one that said, this is nuts. Everybody thought it was crazy, but we said, hey, let's jump in and we're going to get this done. And I put this quote up here from you after this was done, that even though it was crazy, in retrospect, it would be difficult to think about it being done any other way, largely because those resources that were involved in the project, if it had been 18 months, then they all would have been involved over 18 months. So the internal resource drain would have been significant, and we would have run much more of a risk of loss of momentum as folks kind of lost touch with the project or other priorities came up. So that aggressive, focused approach really helped. And then vendor assimilation, really what we mean there is that there were a lot of folks at the table here, a lot of vendors that were putting a huge amount of effort towards this, and it wasn't always easy for them. And the way that we managed that was that we, from the consulting side, we spent time on weekly calls with our program manager, Maggie, and her job was really to make sure that she understood individually what their concerns and risks were so that she could manage them across the project. But then we also would have all the vendors on a call once a week so that they would get to hear what each other's going through. So it became a situation where at the outset of the project, we had vendors that were expressing concern about their role and their influence. And then in the project wrap, we're just very, very pleased with how it had worked out and super excited in terms of the vendor relationships and the way the project was executed. So it had its challenges, a little bit of emotional support, a little psychiatry work, but it all worked well. And then we stayed aligned with the Yale team to make sure that they weren't hearing different stories. Just to close, the project goals were achieved as we outlined. Obviously, you saw the data around alarm management. A couple quotes we wanted to include here. I'll read the first and fourth. From a staff member, the new unit has made an incredibly positive impact on the patients and families. The families love it. I think the communication system is very effective. The technology is amazing, and I've enjoyed the experience of learning it. Again, if you counterpoint that to what Mary Kate shared earlier with the staff being so concerned, that was really great to see. And then from a family perspective, down at the bottom here, one of the scariest moments was when I was holding one twin and the other baby started declining. I was able to use my pillow speaker device to call for help. It just calls out an example about how the very much patient and family first design, we normally think of technology servicing the care team. Here, significant portions of it were designed to serve the family directly. It's a great example. So with that, we'll move to question and answers. Thank you guys for the time and listening in today. Hope it was valuable, but we'll pause here and see if you guys have any questions. While we're waiting to see if any questions come in, to the Yale team, any final thoughts or comments from your end? I know I made the close there, but just wanted to give you guys a last moment audience if you wanted it.
No, again, I want to stress what a successful partnership it was between all participants on this initiative. I wouldn't have done it any differently, and those that were involved, from the staff to other members of the leadership and provider teams, feel the same way. It's had wonderful, wonderful outcomes that we continue to see occur every day, and would encourage everyone to begin looking at this process more closely because of the alarm management and staff having the situational awareness that they've gained in this new environment, which is a new environment for us, but is really an environment for everyone, whatever the patient population. So this application really can transfer to current environments. So I just really wanted to stress that because I think that's important. I don't want people to be focused on this being a NICU initiative. It was, and we came from an extremely different environment, and that's where it shows just how far this technology, leveraging the technology with the closeness of the caregivers and providers, worked so wonderfully well.
Okay, thank you, Mary Kate. Yeah, and I think the question was asked in Long Beach that, is this something that's going to be expanded? And I know the Yale team is looking at where can we pick up and move the learnings in this process, this methodology, the technology relationships, and move them elsewhere in the system. So that's an in-progress effort and intended to go forward. Any other questions from the folks out there on the call? All right, well, great. Well, with that, we'll wrap it. You guys, anyone who's on there needs to reach out. Email addresses are on screen. Feel free to reach out to any of us, and glad to share the content as well if you need it sent over. And we thank you very much. Take care.
Thank you, everyone.
Thank you.
Bye-bye.